Welcome to the National Hispanic Cannabis Council Educational Committee Forum on Cannabis 101, where we bring medical professionals together to demystify the health and wellness power of cannabis to break down the Latinos' long-held cultural taboos and beliefs on the plant. My name is David Sanchez, board member of the National Hispanic Cannabis Council, and today we're bringing two cannabis doctors and my partners from the NHCC's board of directors, Dr. Phil Burns and Dr. Craig Ontell from New York State of Mind, to discuss cannabis and arthritis. As mentioned, my name is David Sanchez, and I attended the University of Colorado Boulder and studied chemistry and biochemistry there. Since 2012, I've taken a big interest in cannabis and have dedicated my career to learning as much about cannabis and its manufacturing processes as humanly possible. Over the course of my time in the industry, I have designed and commissioned multiple manufacturing facilities and have launched dozens of cannabis products nationwide. Guys, I'm super happy to be with you guys today. For today's first guest, Dr. Craig Ontell. He trained at NYU's Rusk Institute of Rehabilitation, where he spent nearly 15 years of private practice in NYC. Craig also served as director of ambulatory orthopedic rehabilitation at NYU Langone's hospital system. And in May of 2021, he left NYU to become CEO for State of Mind Cannabis. Dr. Ontell has personally treated hundreds of medical cannabis patients over the past few years and has had significant success in weaning patients off of narcotic-based medicines and substituting with non-euphoric, non-sedating cannabis options. Dr. Ontell has been published in numerous cannabis articles and has presented at national conferences. Thank you so much for being with us today.
Thank you for having me, David.
Of course. And last but certainly not least, Dr. Phil Burns, Doctor of Osteopathic Medicine. He's been in practice for over 20 years, completing specialty training in the field of physical medicine and rehabilitation, also at NYU Langone's Health Rusk Institute of Rehabilitation Medicine. After completing that training, he founded and has operated a successful medical practice specializing in orthopedic rehabilitation as well as prosthetics. Dr. Burns is driven by his desire to make a meaningful impact in the state's opioid crisis. Welcome, Dr. Phil.
Thank you for having me.
Of course. All right. And today's educational committee roundtable on Cannabis 101, today's intent for our session is really to provide an informative overview of cannabis and arthritis. But before we do get started, I did want to say a few words about the National Hispanic Cannabis Council's mission, which is to educate the U.S. Hispanic community on the health, wellness, and the economic aspects of cannabis to empower their support and participation in the industry, to also help demystify through educational programs such as this one, the health and wellness power of cannabis to break down those long-held cultural taboos and beliefs on cannabis. Guys, let's begin the show. All right, and where do we begin? How do we even get started on this topic? I think
I'll get going here on this one. So, David, thank you for the very kind introduction, and Phil, it's always great to see you. Just for the folks who are watching this, for a little bit of a point of reference, Dr. Burns and myself have been working together since literally day one of medical school. So we go way back on this, and we were very excited when the topic of osteoarthritis came up to discuss with regards to cannabis. And the reason for that is it is the most prevalent disease state or medical condition that walks into our offices on a daily basis.
Wow.
And on a high level, osteoarthritis pretty much affects everybody who's over 60 years of age. Women more than men. Genetics play a role. there are two types of arthritis out there. There's osteoarthritis, which is everybody gets. And there's rheumatoid arthritis and a whole subset of different variations of that, which nobody wants. So when we look at the aggregate of arthritis, we're talking about 100 different things. I like to keep it simple when I discuss arthritis with patients, even before we get into the cannabis end. Arthritis is a term that we've all heard our entire lives. Somebody mentions arthritis, everybody nods their head like this, but the reality is no one really knows what they're talking about. So I'll make it simple for everyone.
Please.
Osteoarthritis. Let's think about my phone here. The surface of my phone is smooth. If I take a pen and put it on the top of that phone, it's no longer smooth. That's osteoarthritis. New calcium, which is what bone is made out of, being laid down on existing calcium in an irregular manner. Like I said, 100% of the world population, 60 and above, at some point will develop osteoarthritis, and mainly in our weight-bearing joints. Rheumatoid arthritis is more destructive. So instead of your bone looking smooth like the surface of the phone, it'll be a little chewed up and pitted away. So those are the two big differences between osteoarthritis, which we like to say is a cat and a dog. You see it every time you walk down the street or go to someone's house, as opposed to rheumatoid and those subsets, which are a little bit more rare to see. Now that we understand at the highest level what arthritis is, the most important part about it and getting folks better is understanding it's inflammatory. And it's the inflammation in addition to the bony changes that causes a lot of our discomfort. And the goal in us as physicians treating osteoarthritis in any way, shape, or form, including using cannabis-based products, is to address that inflammation. Dr. Burns?
I concur with you. The goal in treatment of osteoarthritis is obviously going to be decreasing that inflammation, like Craig alluded to, right? Decreasing the pain and subsequent symptomatology that goes along with that. Improving someone's functional level, improving quality of life, secondarily, and also joint preservation. So preserving that joint.
That's awesome. And I appreciate that working definition, because I'll have to admit, I was really under the impression that arthritis was really the pain of it. And after hearing you say that, I think the inflammation and the pain is just a symptom of what's actually going on. Because I think to your point, a lot of people say I have arthritis, or I know somebody who has arthritis, but they really just know about the pain that they're going through. And so as a follow-up question, how does arthritis come to be in either one of those forms? Or like how do people get arthritis? Is this something that is genetic, or is this something that happens over time by not drinking enough milk? What's the root causes here, or what leads to somebody having arthritis?
So for osteoarthritis, it could be overuse, it could be prior trauma, there's many genetic predisposition. With rheumatoid, usually it's more of an autoimmune disease, and whether that's, again, hereditary predisposition, or just sort of the bad luck.
Yeah.
Either way, someone comes down with either one of these two, and then the treatment plan obviously needs to be respectful of the original cause, right? So when we talk about that treatment plan, aside from joint replacement, right, we're dealing with anti-inflammatories for the inflammatory cascade that we had discussed, right? Some people take Tylenol. Well, let's go back to the NSAIDs. The anti-inflammatories are good in treating inflammation. However, there are side effects and downsides to taking that medications, right? Everyone knows about GI risk factors in terms of bleeds, et cetera. Obviously, if someone's on a blood thinner, that risk goes up and makes that not the best choice, right? Secondarily, they could take Tylenol, which is a good pain medication, but doesn't really address the inflammation. The other side of Tylenol is obviously the liver issues that everyone knows about, and particularly someone that is on multiple medications, as someone with arthritis may tend to be, as it does affect, for the older populations, they may have several different medical issues we're dealing with. And some of those other medications may be metabolized in the liver. That then becomes not the best choice. So it becomes sort of tricky in treating osteoarthritis sometimes based on other comorbidities, other risk factors, and what we're trying to, improve someone's overall health without introducing things that have a sort of risk profile that isn't conducive to its use. The other thing of note is that the chronicity of osteoarthritis, meaning it's a chronic condition, it's not like you sprain your ankle and you'll be better in 4 weeks, is that these medications will likely be sort of long-standing. So then that is something that plays a role in selecting the appropriate medication or treatment plan that's going to give them adequate relief to, again, improve functional level, improve quality of life, preserve the joints, without introducing other issues. And I guess that brings us to what we're here to talk about today: cannabis and the use of cannabis for osteoarthritis. So
I just want to expand on what Dr. Burns just said a little bit. Osteoarthritis affects everybody. And, we said before, it's inflammatory, and that's what's generating the pain. So the mainstay of treatment so far has been anti-inflammatory medicine or non-steroidals, which Dr. Burns just meant. I also mentioned a few minutes ago that folks 60 and above, close to nearly all of them have some degree of osteoarthritis, and it kicks in around the age of 45 or younger for most folks. It is on the weight-bearing joints. A lot of it is wear and tear, like Dr. Burns mentioned. On the genetic end, it's usually more of the rheumatoid-related stuff, but it's also osteo as well. If your mom or dad had an arthritic hip, you're likely going to have it as well, just the way we're built. But what I wanted to touch on was the efficacy and the safety of how we've been treating arthritis and why we're here today with cannabis, which is what Dr. Burns was just about to get into. We have a problem in our seat treating arthritis. The anti-inflammatories have a risk profile that can't be ignored. And the risk profile is GI, the risk of a bleed, or cardiovascular, including the risk of a stroke. Oof. One over-the-counter Advil, Motrin, whatever, ibuprofen generic, whatever we want to say it is, you take one and you do an endoscope or a picture of the GI tract, and you can start to see erosive changes after one pill.
Wow.
One pill raises your percentage or your risk of heart attack or stroke. So none of it is benign. Two, once you reach the age of 72, that's where the American College of Rheumatology has kind of put their line in the sand, they recommend against high-dose anti-inflammatories. Reason being that the risk of a bleed is higher as you age, and there is a razor-thin line between a little bit of stomach upset and a bleed. So these medications are not without risk. Lastly, before we move to cannabis, In order to obtain the anti-inflammatory benefit from an ibuprofen-based product, once again, I'll mention the brand Advil or Motrin, whatever we want to call it, you have to meet or exceed 1,600 milligrams per day.
Wow.
For folks who don't get the math, that's 8 Advils. You're likely not to take that much. So what a lot of patients do is they add a GI protectant, something to coat the stomach. However, frequently doesn't work just due to the science behind medication absorption and how it becomes available in the body. So long story short, with the anti-inflammatories, we have a significant risk profile. Frequently in our elderly population, we can't use them anyway. I won't get too deep into it, but a lot of other medications we take get metabolized via the liver, which makes our long-term Tylenol use a little bit questionable as well.
Wow, so it seems like everything really has a risk that you really need to consider before taking anything. And I think a lot of people think Tylenol or these over-the-counter medicines are quite benign. So it's interesting to hear that you really got to be careful and speak to your doctor about, what you plan on for treatment or what future treatments may hold.
And the beauty of cannabis, since we're about to hop right into that here now, is its anti-inflammatory properties, which the three of us who are running this talk are well versed on. I'm sure a lot of folks who are watching this talk are not well versed on, but we'll talk about that here. So it really comes down to the profile of the type of cannabis that you're using, and we'll get a little more granular and we'll talk terpene profile. And I'll let Dr. Burns run with a little bit of terpene definition here for a minute, and then we'll mention some specific terpenes that have anti-inflammatory properties that when you use a cannabis product that have a higher concentration in those, your outcome should be better. Dr. Burns, you want to touch on terpenes for a moment?
Yeah, so when we talk about cannabis, there are several different components within the plants, and we've discussed in the past calls about the cannabinoids and the endocannabinoid system, and that's the sort of well-known CBD, THC, but also THCA, GBD, CBG, etc. There's other components within the plant called terpenes, and Craig will discuss some of the particular ones, but the terpenes are also components within the plant that provide different health-related or health benefits. You may have heard in the past people taking, recommending different herbal medications, etc. Those are the terpenes, all right, that provide that that health benefit. In cannabis, there are certain ones that we select out in different strains, looking for overall strain of a plant that's going to give you that's going to address the issue we're hoping to achieve, or the health benefit that we're hoping to achieve. That being said, we're selecting out plants in our growth and strain selection that's going to give us as many of the components of the plant that's going to positively impact the disease profile. And then in totality, we call that the entourage effect, where you're getting sort of all of the compounds that collectively acting together will provide the best clinical outcome.
Two of the more prevalent terpenes out there with anti-inflammatory benefit are pinene and beta-caryophyllene. I'm just mentioning two of many. So if we're able to identify cannabis strains that are high in terpenes that have anti-inflammatory benefit, that would be the product selection or the route that we would go to treat folks that have arthritis. When we, another thing which I realize as I'm sitting here and we're talking arthritis is very often patients don't understand what their pain is. And David, you mentioned that a minute ago or a few moments ago. Your arthritic person is going to complain of stiffness in a joint or their neck or their back. Worst upon arising in the morning, that improves when they warm up, unless they do too much, and then they have symptoms again. Dr. Burns mentioned a couple of treatments for it, and really the number one treatment for arthritis is exercise. Stronger the muscles are over any arthritic bone or joint, the better the patient feels. In the cannabis, with cannabis and treating arthritis, we're not limited to one form of use. So whether the patient is going to do inhalation, meaning they're smoking or they're vaping, or they're going to have an edible, which is a gummy or a tincture under the tongue, or even a topical, which I'll get into in a minute, the outcomes should all be roughly the same. When we talk about different ingestion methods, one of the main things to consider is the onset. And in our patients who open their eye in the morning and they have a horrible bone-on-bone arthritic knee and they're in pain, we have them start with either a tincture or a vape or something that's fairly immediate. Yep. For folks that have a lower level arthritis and around 10 or 11 in the morning or noon, they're going to grab for that Tylenol or their Advil. We'll have them start with something a little bit more delayed onset with a longer course of action, like a gummy or an edible. Topicals always come up, and patients always ask me about them because they are fairly easier to use. And a lot of the major pharmaceutical companies have topical applications for arthritis. So I want to hone in on that for a minute. It is very difficult to create a topical medication that properly transduces through the skin. This is a barrier. Obviously, we sweat, stuff comes through, right? So it's a permeable barrier. But we have to transduce medication through this barrier to get to the desired area. That's not easy. The main vehicle that we use and have been using for the past 3 to 4 decades in pharmaceutical world is DMSO. And that is the vehicle that we use to transduce medication. The larger the molecules in the medication, the more difficult it is to transduce it. And the deeper the target we are trying to get to, the more difficult it is to reach. So I'll explain. If someone has arthritis of their kneecap, patellar arthritis, everyone on this who's watching this knows there's not a lot of distance between that kneecap and the outside world. You tap on your knee, you feel it. Got it? So that medication doesn't have to diffuse all that far to get where it needs to go. Now, let's say you have an arthritic hip and you got a lot of cushion in between that hip joint and the outside world. No way is that transducing deep enough to reach that joint. So when we talk about using cannabis products that have anti-inflammatory properties, we need to know what the body part we're trying to get to and how many we're trying to get to. If a patient has multi-joint involvement, meaning their weight-bearing joints, their hip, their knee, their ankle, they're just unfortunately riddled with osteoarthritis, unless they're rubbing lotion on their body all day long, it's not going to make a difference. That individual is best served with a pill form or an edible and inhalable type of form to address their discomfort. The first joint in the body that gets symptomatic arthritis is this here, called the CMC joint. So everyone who's watching this with a stiff thumb or hand, you got arthritis. Got it? And then his cousin is the big toe. So in your patient or your consumer that's looking for relief, that has just isolated thumb OA, a topical that's available at their medical dispensary that's high in pinene concentration or beta-carotene or any of the other dozen terpenes we have identified as anti-inflammatory would be the appropriate course of action. There is no cure for arthritis, folks. I just want to throw that out there here. There's just not. The only cure we have for arthritis in the medical world is replacing the arthritic joint. Secondary to that, we're managing this, okay? Dr. Burns mentioned this is a long-term process, and the individual that has symptomatic arthritis at the age of 40 or 50, and we send folks for hip replacements at 35 or knee replacements at 35, wow. They have decades ahead of them of managing this inflammation and pain. We quickly touched on the GI, cardiovascular, and liver. To date, the safest option out there with the least side effect profile is cannabis.
That's so powerful. And I just wanted to ask a question on those replacements, especially in the younger population. Is that just because they have, a lot of time left and they're just not going to want to be dealing with managing the arthritis? So you just say, hey, get it replaced now. Whereas someone who's a little bit older has like a higher risk tolerance to the surgery or recovery.
No, I'm glad you're asking this.
Why
gets a joint replacement?
Yeah.
Dr. Burns and Dr. Antel do not tell you you need a joint replacement. The patient, and we'll say it's you, David, just because you asked a question, nothing personal. David comes in waving a white flag to our office and says, I've taken every pill, I've taken every shot you've given me, I've done your therapy, please give me a new knee. Until those words leave your lips, folks, you don't need a joint replacement. Got it?
Got it.
Now, the younger patients we worry about, because joints don't last forever, pun intended. They have we replace a hip or a knee, we're going to replace it again in 15 or 20 years. We are. So we're cognizant about that. And then you're right, David, you run into a certain point in time where the patient might not be healthy enough anymore because of other comorbid medical reasons where we can no longer replace their joint. Right. So now we're managing their pain. And this is very important here. Dr. Burns and myself are all about stemming the opioid epidemic. That's what our company's about. That's how we got into this.
Right.
And I mentioned very early in this talk, the pain in the arthritis is primarily generated by the inflammation. For anyone who's watching this who has bad arthritic pain and their first line of treatment is a narcotic, you're doing yourself a major disservice because there is no anti-inflammatory component to that Percocet that you are taking, just so you know. So you are not addressing the cause of your pain. You are only trying to manage the symptom of it.
Wow.
By addressing the cause, very frequently, folks never make it to the opioid. I just wanted to drive that point home. Now, yes, if you are a candidate for a total joint replacement and you're bone on bone and there's nothing left there, I understand and I'm compassionate to the need for the temporary narcotic medication possibly, but as a mainstay of treatment for arthritis, it's not the way to go.
Okay. And so let's dive right into it. Why is cannabis a better option, or why should folks consider cannabis as a potential treatment?
First off, the side effect profile. So the side effect profile really just doesn't exist. And no, everyone who's watching this can pull up any articles they want here, there, and everywhere, and you're going to have a very hard time finding real heavy side effect profile here. Dr. Burns mentioned something very important before that I want to hone in on, and it's called polypharmacy. And that's when you get a little bit older than me, and I'm 54 with gray hair, and you're taking multiple medicine. Each of these medications interacts with the other medications differently. So every time you add a pill, not only is it the medication, but it's the coating or the substrate. All of these variables factor in. And after you get past a couple of pills, you don't know what's helping or not helping. It's very hard to figure out the interaction on the absorption and all of this. Cannabis doesn't have any of that. It's a different system. It's the endocannabinoid system. We're not seeing any of these interactions. The other thing, and it just came up as I was visiting my in-laws in Florida, the data out there shows that in your elderly patients with polypharmacy who are using 5 or 6 pills, when we add in a cannabis-based product, whether it's for pain, anxiety, sleep, we could go on, they tend to drop 1 or 2 of those prescription pills, just so you know. So they're overall simplifying their entire medication regimen, and they're slowly eliminating potential side effect profiles and interactions. It's just a safer choice.
That's huge. That's huge. And just so we're being fair and looking at both sides of the coin, is there any health concerns with say maybe the lungs if you're taking cannabis and doing vaporization or inhalation, or is there also a taxation on the liver when you consume edibles, cannabis edibles? And is there some of that to weigh out as well?
Yes, there is. And I'll let Phil finish after I start, because I know he wants to hop in on this one. Smoking's bad. I mean, we spent decades pushing forth, anti-tobacco campaigns about how bad it is. Smoking's bad, period. It is. And vaping it's another form. There's a lot of literature out there, plus minus, that compares the both regular smoking and vaping to the two of them. So neither of them are really great. As far as the liver goes, and I'm glad you asked this as well, and it's not necessarily, it is related to this. So we want our patients to get lasting effect on the medication that they take. And we don't want them reaching for another pill or to take something again every hour or two. A, it's inconvenient, and B, they're just not going to do it. So they're going to reach for another product that we probably wish they wouldn't. They're going to say it doesn't help. They'll go for something stronger. The edibles, which is what you asked about, they go through a second pass metabolism through the liver. So they do get metabolized again. Dr. Burns, anything to add to that?
Yeah, I mean, this is the, like we've discussed multiple times, this is the reason why it's best to not self-medicate, but talk to your provider and, discuss what options are available to you and what's the best option for you relative to your overall clinical picture, right? So if you, for the sake of argument, say have COPD, right? Smoking is probably not going to be the best for you, right? If you have, sort of, whatever liver pathology, a second pass metabolism through an ingested means might not be the best for you either. So it's sort of taking the totality of your whole healthcare picture, discussing it with your trusted provider, and determining what the best route for you is. So we talk about medications. We're talking about the so with respect to cannabis, the strain selection, which we discussed, right? The formulation, the route that it's being administered, dose, and intervals, and all of those will be best discussed and decided. You know, your interaction with your healthcare provider and determining what the best overall formulation for you is. One thing I did want to touch on with respect to cannabis and arthritis, we started to allude to this earlier, is to your question of why cannabis. There are receptors in the synovium, the joint capsule, to the endocannabinoid system. So we know that taking cannabis product will have effect in that joint and restoring sort of the homeostasis that we discussed again in previous talks. Additionally, CBD is known to block cytokines, right? And when we talk about inflammation, it's a chemical cascade that's occurring, right? So if we can interrupt that cascade along the way, we're blocking inflammation.
We don't have a lot of new products coming down the pipe, is what we call it, in pharma land for osteoarthritis. We just don't. A lot of the push is more on something called biologics, which are dealing more with the autoimmune or the rheumatoid arthritis end of it, but not what I call the cat and dog end, which is the osteoarthritis. And that's what you're going to see. As a practicing provider, the two of us, someone comes into my office with knee arthritis and they tell me that they're taking a handful of Advils a day for the past handful of months, or they tell me that they're taking some low THC gummy, I am much more pleased to hear that they're on the cannabis-based product every single time than I am to hear that they're on long-term anti-inflammatories. Because the other thing that we need to do in the medical world here is once our patients have been on anti-inflammatories, which today are the mainstay treatment for osteoarthritis, after about 90 or 120 days, those anti-inflammatories make the red blood cells stickier. That's not good. So we sit here and we worry. The longer these patients are on these medications, not only do we have the stomach or the GI risk, but our stroke and heart attack risk or cardiovascular risk goes up all the time. So I personally, and I can write anything under the sun with my medical license, feel more comfortable for my patients that are off those anti-inflammatories and using their cannabis-based products. And we've said before, just to be clear, because not everyone watching this has seen our other talks, taking a cannabis product does not mean you're getting high, folks. I just want to say that again and again and again. There are a plethora of cannabis products that are formulated which will give you the desired effect and benefit we're talking about that will not affect you cognitively. I just want to put that out there so everyone understands that.
No, thank you for saying that. Thank you for saying that. And I think those are some of the most common misconceptions that we often hear about is, I want to try it, but I don't want to have like this psychoactive effect, or I don't want to lose control, as some people may say. And so it's definitely good to hear that there is those options available. And as you spoke of kind of the long-term effects, and I think folks often think that Tylenol is maybe not addictive, or people are dependent on it. But I do know folks that, and I don't know if it's more of like a psychological thing, like, hey, I'm just in so much pain that I need another Tylenol. But is there like a tolerance that is built up if you are consistently taking these Advils, or is it just more of a long-term effect that like, hey, if you are consistently taking this, you're just going to put such a toll on your liver? So is that what can we say about that in terms of like, are people building a tolerance using this Tylenol?
Bill, you want to grab that one, or you want me to?
Yeah. So, the Tylenol by itself, we're limited in dose by the concerns with the liver. So we stay below 3,000 milligrams, or 2 extra strength every 8 hours. We stay below that. If it's not working for you at that dosage, what we'll do is switch you to something else or recommend something else, rather than sort of ratcheting up the Tylenol.
The tolerance, and tolerance is tough. Everyone's pain threshold is different. It's, pain is subjective. It's, you mentioned, and I don't think it was the word addiction that you just mentioned, or maybe habit forming. I'm not sure the exact term, but patients become creatures of habit. You just do. And if you get used to, in your mind, waking up each morning and taking that Tylenol the same way I drink my 2 cups of coffee, that's just who you are and where you are. It's, some folks only walk on the right side of the street instead of the left. It's a lot of these things become ingrained over time. It's so I wouldn't say it's addictive, and that's the word that you used. I've never heard of someone coming in addicted to the Tylenol or the anti-inflammatories. It's whether it's a true need or a perceived need, they have a reason behind it. It's you can certainly, from an addiction perspective, you can take someone off their Tylenol and they're not going to go through a withdrawal, put it that way.
Got it. And so what kind of cannabis products should patients be looking for?
If we're talking about isolated arthritis and it's on a joint or a body part that's close to the outside world, and there's a topical available, that's your best route to go, because you have less of a systemic absorption of the product. So for folks that really are, this is all I want, I'm swapping this out instead of my Advil or my Voltaren gel or whatever they're rubbing on it, absolutely. For folks that have more of a, I don't want to use systemic arthritis, but more of multiple joints and body parts, topical's a waste. You're gonna be rubbing stuff on yourself all day long. So I would move or recommend something more on the edible or the consumable route, because your patient is going to end up with a good 6 hours of relief due to that second pass metabolism that Dr. Burns was just talking about a moment ago. So that is the course I would go. But going back to what I said before, it depends on how they start their day. And if they're in significant pain, we'll start them with a tincture or a vape or something that's very fast acting.
Immediate.
And then immediate acting. And then when that wears off, we'll have them on the pill form or the edible form for the rest of the day.
Perfect. And so and we talked a little bit about terpenes. And so are you guys saying folks should be looking for a specific strain that's high in these terpenes, or is there some staple strains that you say, hey, these are really good for arthritis, or is that something that folks should talk to their bud tender to see what kind of strains are available?
That's where the importance of actually going to a medical cannabis dispensary comes into play here. And you really need to have an educated bud tender or the medical dispensary that you're going to really needs to have embraced their technology end of their business. And you should, at this stage in the game, be able to make an informed, educated decision at that dispensary, where the folks there should be able to guide you to the right product based upon that terpene profile. I know that was a long paragraph I just said.
No, it's good.
But at this stage in the game, as far as we're concerned, it's unacceptable to not receive that information when you go to your medical dispensary. And I mentioned the word medical a few times. Patients and consumers need to be very careful about visiting unlicensed cannabis facilities right now, because you don't know what product you're getting, and it's very dangerous. Yeah. So definitely, that's 3 definitely, stick with the licensed medical entities.
Yeah, okay. No, definitely good points. A lot of that stuff is untested. The manufacturing in those facilities might not be up to snuff. And I think just for peace of mind and for consumer safety, I would totally concur on your recommendation. What kind of information is available, or what kind of information should they ask from their medical dispensary if they are considering moving forward with treatment? Do they want to see cannabinoid percentages? Do they want to see like specific terpene percentages in there, or you just want to make sure that this strain or this specific product is kind of going to help me out?
Bill, you want to go for that one, or should I?
You can take that. I just quickly say probably a higher CBD or a 1-to-1 ratio to start, and go low and slow and determine efficacy.
Yeah, you really want to. It's the terpene profile is important. It is. It's something that's been ignored and overlooked, and a lot of folks who are watching this hear about one thing, THC, and that's how consumers shop right now, based upon THC. For reference, you guys are buying grain alcohol. Got it? Like, not a good idea. The higher the THC, folks, that's at the expense of the terpene profile. And just for folks that don't understand, the terpene profile is what gives you all the flavor, all the happiness, all the benefit out of that cannabis product. So you don't want to wash that out. You want to see that terpene profile at that dispensary, at that point of sale. And they absolutely, when they test that product, they list the percentage and the number of terpenes that are in that. What the consumer wants to look for is an overall a varied terpene profile. Yes, I said here certain ones are better for arthritis than others, but if you're purchasing a cannabis product and you're looking at the, not ingredients, but the list of what was tested in there, and it's showing THC and CBD, and only 2 terpenes showed up in a percentage high enough to test, you want to move to the next product, folks. It's not, God, and David's shaking his head because he gets the science behind it. You guys are buying grain alcohol. Got it? So it's very important. And a lot of medical providers or retails out there will have that out there, and it should be there. And that's something the consumer really needs to be looking for.
Absolutely. And I always tell folks, cannabinoids and terpenes have an inverse proportional relationship. As one goes up, the other goes down, and vice versa, right? So people who are, to your point, buying the grain alcohol, you're not getting much terpenes. And so Dr. Phil Burns also recommended something with maybe a lower dose that's going to help you have more terpenes in that composition and should therefore kind of get you a better efficacy. So always super important to kind of get some of those relationships. You can't have it all, right?
No, you can't have it all. And, as the research becomes more available and as data becomes more granular, this conversation we're having today and 12 months from now is going to be better just because we're going to know more. And in 24 months from now, it's going to be better than this when we revisit this in a year. On the physician end, for the folks who are watching this, and you go to see your cannabis doctor, they're also learning at this point, just so you know. So it's hard on them sometimes to give you a direct answer because we're still learning the right dosing for things right now. Dr. Burns mentioned something before, which makes us cringe inside when we say it, start low and add from there. We're only saying that because the data is becoming available, but it's not granular enough for us right now. Yeah. But don't let that scare you away from cannabis. If you came to see Dr. Burns and myself for blood pressure, it would probably take 2 or 3 or 4 visits of changing around your medicine until we found the dose that works for you. Got it? This is no different, okay? Just as good or just as bad, it's all in the same boat.
Trust the process.
It's a process.
Trust the process. Well, I think we're coming up on time, and I think that's a great kind of note to end on, folks. Trust the process. Talk to your medical provider, do your due diligence on your dispensary, know what product you're getting to, and live a happier, healthier life with cannabis and cannabis treatments. So thank you guys for joining us on today's episode and today's conversation of Cannabis 101 and arthritis. We're thrilled to give you guys another educational seminar, and please tune in for our next one.
Thank you, David.
Thank you.
Thank you, Dr. Burns.
Thanks.
Thank you, everyone, for watching. Feel free to ask any questions. David will be happy to answer them.
That's right. That's right. Thank you, guys. Have a good day.
Thank you, everyone.